We've learned that aortic regurgitation is quite common, especially mild and moderate forms, that significant aortic regurgitation causes volume overload, which poses the risk to damage the left ventricle and cause left ventricular deterioration. If we evaluate these patients, we have to first look at the 2D image, especially the valve itself, the morphology of the valve, and the surrounding structures, and to also look at secondary findings such as the dilated hypercontractile left ventricle. With respect to quantification, it's very important to always use an integrative approach, to look at the jet, especially the proximal portions of the jet, with the PISA, the flow conversion zone, and the vena contracta. We can also use the Doppler spectrum, which however does not work in all patients. The retrograde flow from a suprasternal approach to look at how much blood flow regurgitates back into the left ventricle. And then also the indirect signs of aortic regurgitation, which I mentioned previously. So what are the indications for surgery? Acute AR, this is an emergency, especially if AR is not tolerated by these patients. And in chronic AR, if the patients are symptomatic, if they have a reduction in left ventricular function, in other words, an ejection fraction below 50%, and if there is excessive increase in left ventricular size, the cutoff values here are more than 70 millimeters end diastolic diameter and more than 50 millimeters end systolic diameter, or if you index the end systolic diameter to the body surface area more than 25 millimeters per square meter. So if you want to see more examples of patients with aortic regurgitation, please go to the Atlas section of our platform. There you will find numerous different examples of patients with different degrees of regurgitation and different etiologies. As we pass along with this course, you will note that you will encounter aortic regurgitation quite frequently because, as you know, aortic regurgitation is a frequent finding.